our big focus is constipation, and our aim is to reduce the rate of opioid-induced constipation in adult elective surgical inpatients at Manukau Surgery Centre, first and second floors, by 30%, baseline being 39%, and we want to get them down to 27% by June 2016. So our inclusions, all adult patients having elective orthopedic, gen surg and gynae procedures, but we're not looking at peds or bowel surgery patients. Okay, we've tested a number of interventions, so we've done 9 PDSA, some are still in progress, and I won't go into all of them. Some of the notable ones, of course, our patient information pamphlet is really out there and it's in use at the moment. We've been testing prescribing sticker in different environments. We're now in pre-op and PACU. Looking at a stamp on our actual daily care plan just to really highlight key parameters around the bowel management. So those are the resources. Our patient information leaflet, which is really well in use now. The additional section, bowel section, is on the daily care plan, but we've got a stamp that's going on just to really highlight the way we want to document it. A guidance for nurses, administration, and for the doctors to ramp up the laxative use. So starting with Laxol and ramping it up over the period of time. And the prescribing sticker, which goes on the regular part of the med chart, just to really push and then, get the prescribing up there, the co-prescribing. Okay, so data, and we've really focused heavily on data because it's king. MSC, Manukau Surgery Centre 1 versus 2. MSC 1 is protocol driven by ERAS, Enhanced Recovery After Surgery pathway, and so they were right up there with the co-prescribing of laxatives with opioids. MSC 2 doesn't have ERAS because it's gynae and the other surgery that goes in, but they've really caught up enormously well over the time period. You can have a look at that. So that's the co-prescribing. And then patients receiving at least 1 dose of laxative. Once again, ERAS is really, in MSC1, they were right up there, and MSC2 has caught up very, very nicely. Patients' bowel monitoring's been done really well across the 2 areas because we have the daily care plan, so that was never a problem in those wards. Then discharge prescribing, co-prescribing, and once again, MSC2 has caught up very nicely, compared to MSC1, which was ERAS pathway driven. Okay, so our balancing measure being diarrhea, and that's not been seen as a problem particularly. We're not seeing it as an issue from the laxatives. And then we've got 2 ways of looking at outcome. We've got patient self-reported constipation. Constipation's really what the patient says it is, and we've found that more and more. So we've looked at that versus, so in the 2 wards at MSC1 and 2, that's an interesting spike in MSC1, and that was a time when they really focused asking patients about their bowels. So the more you ask, the more you get told, well, actually, I do have some niggles. So it's quite interesting. So lots of improvement on outcome in terms of constipation reduction. And then the other way of measuring is the targeted data collection method. 5 patients per week from both, from each area. So that's just randomized and together a total of 5 patients versus the self-reported, the aggregated self-reported, which is 10 patients. So that's MSC 1 and 2. And so you can see there's quite a difference on the 5 patients per week with the targeted collection versus the patient self-reports, which is we're much happier with that methodology because, once again, it's patient-centric. So key lessons and achievement: a defined management pathway optimizes adherence to processes. It's really clear that the ERAS pathway has got patients right up there already in MSC1. So we're looking at having very clear pathways with our constipation prevention. Embedding constipation prevention into business as usual, so all the documentation and processes and practices like admission, daily care plan, discharge templates, really critical. And a very central part of what we're doing is patient partnership. Without the patient being at the centre, this just isn't worth even considering. So patient-centric, co-design of our patient information pamphlet, monitoring of bowel function by patients in conjunction with the nursing staff, and we use our patient information pamphlet for that, for the education and the documentation. And then, of course, the two methods which I've spoken about of looking at constipation, the operational definition, 3 or more days since the last bowel motion, which is not realistic and for patients, whereas the patient-centric method of patient self-reported constipation is actually much more meaningful. So struggles, always going to be rotating house officers, discharge planning, what do we do? You know, patients go home, how do they know what they need to do? And very short length of stay at Manukau Surgery Centre, average of 3.2 days versus the operational definition of 3 or more days since the last bowel motion. After hours prescribing, you know, limited house officers to do that and cover both floors. Okay, so successes, we've got excellent engagement and teamwork by the interdisciplinary group, very strong team, and the pilot sites, and from the leadership of our DHB, great buy-in and support. Improved patient partnership, 3 patient stories, patients very willing to share, and good progress with resource and pathway development, positive changes observed in processes and outcome. And just some, you know, really patient focus, they're the centre of everything we do, and great team. So that's us. Thank you.